Okay, today's webinar, titled Revealing Four Keys to a Better Transportation System Between MCO and Broker, is brought to you by Momentm, who's a longtime supporter of MHPA and our member health plans, and they are a silver partner. I'm excited to welcome William Rutherford, Vice President, Welltrans NEMT Indiana Brokerage, Chad Salfrank, Summit Managed Solutions, which is formerly Indiana Medicaid with Anthem, and Mitchell Wolf, Vice President, Momentm Technologies. I want to thank each of our panelists, and with that, I'll hand things over to them.
Thank you very much, Patrick, and good day, everybody, and thank you for taking time out of your busy schedule to join us. Today, we're going to be talking about transportation and the relationship of MCOs and brokerages. As Patrick mentioned, today we have William Rutherford and Chad Salfrank, and the journey between these two organizations started in 2017 and culminated in 2020 when Welltrans NEMT took over the brokerage, Medicaid brokerage in Indiana. And Momentm was able to provide technology to help facilitate that. And since then, it's been about 3.5 years where we've been working together on behalf of members and the good folks in Indiana. We're going to start with a few questions and areas of conversation, and we'll kind of pivot back and forth between William and Chad. We can share different things that we've learned. The idea behind our conversation today is really we're targeting two types of folks in our audience. One, those of you that have a lot of transportation experience, and we certainly hope to share with you some best practices, some really innovative ideas and thoughts that both of these gentlemen can share with you, as well as those of you who may not have a very deep appreciation for transportation. But at Momentm, we often say that transportation is really the first step to delivery of great healthcare. And given that's all of our mission, I really look forward to our conversation today. So jumping right into our first question and topic of conversations, it's really about transportation network companies, TNCs, so the Lyft and Ubers of the world, and there are a few others. But we've been partnering with them, and let's just start with, why would you want to work with a TNC?
Sure, I can jump in and take that one off the bat here. I think, those TNC companies, Uber and Lyft specifically, I think that, all of us are more familiar with, in the setting of NEMT, network is a huge issue. Having providers available is a huge issue. And just having someone as a supplemental provider there where you can get members to trips when they need to get there, not necessarily relying on them totally, but having that, pinch hitter to be able to come in, step up to bat, provide those services, get people to trips when they need them, is huge for us. And, early on in, my experience with NEMT, ride shortages of providers and getting people to where they needed to be. I mean, that's a huge pain point, creates abrasion for the member, potentially bad, health outcomes. Your regulator gets notified of those things often. You have to report those issues, missed trips and whatnot. And then just having someone there, a company there available with, seemingly an unlimited network, trying to recruit drivers all the time. It's been a huge help from my point of view, and just being able to get folks where they need to be, when they need to be, is something to supplement, the already existing network that we've had.
Mm-hmm. So is it you supplement versus all or nothing? Yeah, William, what's kind of the, when are they the go-to partner?
Well, I think it's a circumstance where you have to look at the situation that you're involved in. There are pros and cons to working with TNC companies in an NEMT type environment. In the pros, like Chad mentioned, they have a little wider range of availability. It's typically in the early evening and even into the late evening. So when you're talking about things like hospital discharges, they're frequently available for circumstances like that. They run in heavy load periods. So when you're at your busiest and you need the extra set of hands to be able to do things, that's typically where they're at their largest volume of available vehicles. And then likewise, when you get those trips that are things like pharmacy visits or methadone related visits. You're talking about a trip that might come in and only be 5 or 8 minutes long and turn around and back, and not counting up your vehicles who have a lot of scheduled traffic and having to wait for somebody for 5 or 10 minutes and turn around and come back. You can do a Lyft in and an Uber out or whatever you need to be able to do to be able to address that. So there are some advantages to that. The cons to it that you have to be able to deal with is it's not a consistent network presence. When you're dealing with a commercial company, they're open for a period of time with X number of vehicles, and you can stack what you want to do to be able to schedule with that. In the case of Lyft and Uber and the other TNC companies, you have a scenario where you have to sort of plan ahead by load management. The technology that we utilize with Momentm is native to both the Uber and the Lyft platform. So we can see those cars in real time to know when they're and available to utilize them. But it's not even really just enough to know about when available to utilize them. You have to invest your staff time in learning where peak periods is or in your geography. So like we meet with Uber and Lyft every 2 weeks to go over where do you have increased drivers available? Where are there new hires? What are new areas that you're covering? So that we can internally teach our team to recognize opportunities to go, hey, this may be an opportunity that we can use an Uber or Lyft vehicle in that we couldn't use it in 30 days ago. But it's not just a plan and forget it type of environment. You have to develop a specific strategy for that provider, and you have to educate your staff when and where the appropriate time to utilize it is, because they can't take every trip that a standard provider can, and they're not there every time, and they don't generate claims in a standard methodology. So your entire team has to understand how to deal with that to make sure that you're using it appropriately. If you do that, they can be a very valuable resource, because there's no NEMT program in the country that's standing around saying, we've got too many drivers, we've got too many vehicles. Everybody realizes the entire problem is suffering from a shortfall of supply and availability. So if you can figure out the proper way to utilize it, you can help manage some of that supply and demand curve.
Mm-hmm. And I'd like to talk a little bit about the if you can elaborate, please, on the claims portion. I just want people to just really appreciate that nuance and that importance, if you could.
Yeah. So typically, most MCOs from their broker want a completed encounter claim, a full 837 transaction that comes back with all the HIPAA compliant codes and HL7 priorities. And I mean, it's a single encounter claim is probably like a 9-item layer formatted field that has to be done. A lot of providers understand how to do that because they've been working with Medicaid plans for years, but Uber and Lyft is a commercial facility service. So what they generate looks much more like a commercial invoice and not an encounter claim. And so you need to be able to absorb that information and match it up against your trip history, and then be able to translate that into a fully compliant 837 transaction for your MCO client to be able to absorb, so they can compile that into their billing on the other end of it. And Uber and Lyft are not an organization that has internal, and other TNCs generally don't have the internal to do that, to translate what they provide to you from their platforms and their trip completion data to get them into more of a compliant claims transaction format for Medicaid to be able to accept. We can do that natively because of our integration in conjunction with it. Other platforms, custom platforms, in-house platforms may or may not be able to do that, in which case it becomes a manual process. And if you're running at any kind of volume in that process, you could get overwhelmed in a manual process pretty quickly. If it's a small volume, you might be able to do it. If it's a large volume of trips like we operate with the TNCs in Indiana, we would be overwhelmed pretty quickly trying to do that manually.
Yeah, to tag on to that a little bit, early on when Uber and Lyft were getting into, wanting to do some healthcare rides, they talked to plans directly. And one of the, my concerns with that was, are these going to be regular encounters that we can, send to the state? Will they be covered? Will they be built into our rates following up? Or are they going to be value added benefit trips where, those don't necessarily count towards rate setting? They're not official encounters or approved claims, but you're just doing that as a value add and not really getting reimbursed for that specifically from the state. So in my mind, it's been great. We talked to them a lot and how they could integrate, but then as it went into, working with WellTrans and getting them integrated there, it was great from my perspective, being at the plan, not having to deal with, well, how are we going to get the encounters done? Who's going to do that? Where are they going to live? Is it just going to be a VAB? How do we assess that? How do we approach the state about getting reimbursed for that VAB? And is it going to explode? Who's going to manage that? Keep eyes on it. And so it's been great to be able to pass that piece off and not have to manage it from the plan perspective.
And when you say hand it off, are you talking about just a single file with all of the trips rather than having two systems of record?
Just basically that relationship. So
Okay.
on onset, it was like, okay, we're going to deal directly with Uber and Lyft, and then we're going to manage that relationship and try to supplement here and there, or, provide these trips. And now instead, it's essentially, and Will may differ on the language, but I feel like it's another provider in their network, and they're, meeting with them biweekly, taking care of that whole relationship. And now as from the plan perspective, I don't have to try to manage that off the side of my desk or do any of those things. It's all part of the package of going through an NEMT broker, and they're just another provider, that's helping out with the network from my perspective.
Right. Hey, but before we jump on to the second question, let me just ask you, are there any next steps that you see or would like to engage with, or how Uber and Lyft are offering anything new and anything interesting?
Well, we have been participating with Lyft in what they call their Lyft Assist program, which is a beta project that they rolled out a couple locations in the United States. I don't think they're beyond 2 or 3 right now, but it is essentially a training service that they provide for Lyft drivers who can come in and do things like carrying groceries from a car, or if it's a crowded waiting room that doesn't have visibility of parking lot, can come in and announce themselves so that somebody can come out. It's not quite a hand-to-hand level of service, but it's a level of service that has risen above what typical TNC does, which is I just pull up and wait for you to come out the other side. That's increased the flexibility in some areas where we can now use them under a scenario that might not have been a typical TNC eligible trip that we can deploy them with in conjunction with. And we're also working on, I'm not even sure if it's live yet or not. Mitchell, you know better than I would, whether or not Lyft Assist is currently live in the Momentm platform right now, but I believe it is. So that's even integrated. So as we were talking about before, we can order a higher level of service for members who don't quite need a hand-to-hand, but need more than just pull up out front to the curb, and open options and availability with that. The one other thing that I'll just add in about brokers working with TNC companies, personal opinion, it's not enough just to contract them into your network. Their operational model, while valuable in an NEMT brokerage platform, is not inherently like other NEMT companies in that platform. You got to make an effort and make sure that you meet with them on a regular basis, understand what challenges they're encountering, make sure they understand what challenges you are encountering, and have an ebb and flow of information that goes back and forth between the two entities, whether it be Uber, Lyft, Z-Trip, some other type of organization that's operating a TNC model, because it's not a set it and forget it program. And to Chad's point earlier, part of having a brokerage partner that's willing to work with that for you is you do have to frequently engage them and get them to understand what's working, what's not working, and where adjustments need to be made. It's not just simply, hey, just enroll them in the network, start sending out, everything will go fine.
Yeah, I think that's such an important piece to take back. Transportation, for those of us that have been in it, we all have gray hair or no hair. It is a challenging yet rewarding area to work on. But certainly if you stay on top of it, and I know that we're going to flip into our next topic, and we'll talk more about that, but you really do have to stay on top of it. And so regular cadence of conversation. And it was really interesting to hear, Chad, you talking to TNCs. I know, William, you and your team have regular meetings with them, as does Momentm. So, it takes a lot of maturing of relationships and building of trust to make this, 3, 4, 5-way kind of relationship really effective on behalf of our members that we serve together. So moving on to our next topic of conversation, fraud, waste, and abuse, FWA, in transportation. So, It's always been on CMS's radar screen, as it should. It certainly accounts for significant dollars, and they have let us know that they're going to continue to keep an eye. So how are we preparing, and what are we doing to make sure that we partner with CMS and are prepared?
Yeah, I think it's always been on my mind and looking at the data, and it's a part of the industry or part of healthcare where it lends itself to fraud, waste, and abuse. You got a lot of providers. There's not a lot of oversight. We're not talking about doctors and having authorizations and all those sort of things. And it's kind of pick a member up from A to B, right? So there's a lot of opportunities for things not to go as planned, or maybe some abuse, waste, things like that are going on. So it's always, from a plan perspective, it's always on my mind, and trying to find those things. I think it's easy to find some of those well after the dust is settled and claims have come in, and you can look at patterns. One of the challenges then is, how do you find these things, more in real time, closer to when transactions are actually happening, when rides are scheduled, and things of that nature. And I think it's really, it takes a lot of collaboration with your NEMT broker to figure those things out, get more active data. They're talking to members, sometimes daily when they're scheduling rides. They may have better information, demographic information on how to reach your members than you do. At times that's been the case where that member's calling, they're leaving their address and phone number. The Medicaid population often more transient than typical population, and the address and phone number we have at the plan may be old and outdated. We can't get a hold of this member to help manage their conditions. But that's a point of entry. We can talk to our NEMT broker, get that information from them, try to manage things, get them to fill out surveys, do all those sort of things that we need to get. But I think it's just a constant back and forth on what are we seeing, what are you seeing, and having to have that channel be open. I think from a plan perspective, additionally, this is viewed as kind of an ancillary service, in the vein of maybe dental vision, transportation, where you hire a third party, has a network, they adjudicate the claims for you, you pay an ASO fee, or you do a risk deal, something along those lines, and then you don't have to think about it too much. This one with NEMT, I kind of thought that going in. It was a new benefit in Indiana at one point. It's like, okay, we got it done. The deal signed. But then as things start running, you start seeing patterns and things that are happening. You realize, hey, we got to collaborate here. I got to know what's going on. I got to have we got to get better deals with these certain providers. I'm seeing this. What are you seeing? All those things are really active things that need to occur. And then there's more management from the plan side that needs to occur on where these members are going, than you would have planned ahead of time with something like a benefit, dental or vision, where they've got, one vision trip a year, one pair of glasses, or two dental visits. Well, we've got SUD members that are taking, 300 plus trips per year, to methadone clinics. I mean, there's a lot more hand-holding that needs to occur. And I think, you really need to trust your broker and have that open line of communication if you want to be successful.
William, what would you add to that in terms of patterns and oddities, and what do you look at? I think we may have lost William for a minute. So, Chad, are there specific, oddities that you've uncovered before?
Yeah, there's many. I mean, you can look at stuff, especially after the dust settles. You can look at what are costs per provider, per driver, and see patterns where things are out of control. Maybe that if you're looking for some sort of waste or abuse, maybe on the specific driver side or a certain company. Looking at mileage per member, how much are they driving county to county? What are my popular counties where everybody's coming from one county to another? You've got rural situations. Obviously, every state's different in how that plays out, but there's certain cases where you wouldn't expect so much, your members to have to move so much to get care. Certainly there are those cases, but those are places to focus on and try to figure out, hey, where's the risk? Where am I seeing things I'm not expecting to see? And then working with the broker, hey, what's going on with this? This looks like the driver's multi-loading. These people are all around the same area. Can you confirm this? Can we get this issue taken care of? Things of that nature. And then, also that feedback, they're looking at the data too, and then trying to figure out, well, how are we going to, make the network better? I mean, it's really, the network is their responsibility, and the prices that they've negotiated on that network. The utilization, can be more on the plan, like how there are members. But if we can collaborate on what's going on, where our members need to be, can we shift that? Then can you help us alter what the network looks like? Can we get a better deal in a certain area? Those things, I think that's where you have opportunities to collaborate. But there's always ones and twosies where you find out after the fact somebody went and there was an eye doctor facility in a mall. And then why would somebody go to the eye doctor 4 times, on the weekend in the same month, regular optometrist? Well, that's where the mall was, and somebody figured out that they could get a trip there. And there's always little things that happen. I mean, you can, run yourself ragged chasing those down. Obviously, no one wants those, but you're looking after some of the bigger things where, could have standing order trips where people, continue to bill. Members are going way out of range. It's an abusive situation where they're going to a dentist that's 90 miles away when they could go to one, 5 miles away. Those are things you're always looking for, and they certainly happen. But coming up with ways to get to those quicker, is always the best practice, and trying to match them up with claims too, as soon as you can. Obviously, there's latency and completion of claims, but that's something we always try to do and manage and see where the outliers are, and then how do we shore up those deficiencies.
And let me ask William about latency in claims and some timing differences. What's your experience with that challenge?
Yeah, so typically, a provider claim may come into a managed care organization anywhere up to 90 days or longer after treatment is received before they be able to get those claims and match up. And this is one of those areas where I always come back to, is your transportation broker a vendor, or is your transportation broker a partner? If it's a vendor, then principally most of that fraud, waste, and abuse matchup work is going to fall back on the plan itself, because they're going to have to come back and go 90 days later, was there a matching clinical claim in conjunction for this trip that we paid 60 days ago or more? And all that, and then how do I notify the transportation broker? And then what does the transportation broker do it? If they're a partner, your partner should be having checkpoints that are going on and happening during that claims latency period to do things like, we typically run our top 50 highest volume providers, and we do spot checks with providers to make sure, hey, just checking in, did this member attend this appointment on this date that's happening in the weeks immediately following the trip and appointment, to be able to say, hey, yes, this trip happened. It looks like there's some consistency here for both members and providers to make sure that they're in the right location. If you're a gas mileage reimbursement, checking in on the logs every once in a while that they turn in for gas mileage reimbursement, go, hey, did you see the member on these dates? And just confirming that everything there is accurate and in line. The second thing is, ask your transportation partner, how many ride-alongs do they conduct on an annual basis? Just to make sure that things are going well in the inside of the trip, and 2, that drivers and partners are doing the things that they're supposed to be doing during those trips, and making sure that those trips are actually happening and occurring in the way that they should be occurring. And the third element of that is, what are you doing in survey follow-up with the Medicaid community to be able to find out how the people who are riding with you are experiencing trips? Are people getting there consistently? Are they late? Anything odd happening in the course of those trips? And then making sure that the data sources that you grab all 3 of those items from are talking to one another. Our grievance team and complaints team meets frequently with our claims team on a weekly basis, just because things that are going wrong on a member end are often frequently an indication of something that wasn't happening right at a provider end, and subsequently means that we should do a look in and see what's going on. Even if it's just as simple as calling the member and finding out, or if it's doing a ride along, or if it's keeping somebody on facility check for a period of time. Those types of things that you do during that claim latency period can head off a lot of problems. And even if ultimately it doesn't come out to be a fraud, waste, and abuse problem, even if it's just a member education problem or a provider education problem that you're implementing in, you are creating a better program and a better utilized relationship for that brokerage in the long run, even if it doesn't catch anything per se that adds up to fraud, waste, and abuse. The other thing that's kind of ironic about transportation is, because transportation is not a perfect system. It doesn't work right all the time. People have car breakdowns, people have no-shows, things along those lines that happen. You know, is your transportation provider partners looking at records that are too perfect? If somebody's taking 500, 800 trips consecutively and not having any issues, maybe they're just a very lucky driver and provider, but maybe something is going on there that you look into, because there should be some no-shows, there should be some late pickup, there should be some vehicle issues that came up along those periods of time. And if they're running an absolutely golden track record, that's an indication that maybe you ought to look underneath the covers and make sure what's happening really should be happening here, because you have a responsibility both on behalf of Medicaid as well on behalf of the plan who's your client to do the things that you can do to try to uncover those and make sure the program is clean and accurate.
So I like the ride along. Too good to be true is sometimes too needs some attention. Latency management and understanding how you need to work with them, digging into trip purposes and trying to tease out like what Chad was saying is, you know, are there better places, you know, when you start looking at those metrics, distance travel, time, frequency, time, you know, time of day, time during the week, you know, what can you learn at the aggregate data? And, you know, you catch a whole wave of items and issues up front, and then you can also catch them when you have a bigger data set a little bit later. So it seems to be a cycle that doesn't really end. You know, it's
rely on just as simple as, was the trip does the trip fall within prior authorization guidelines? Because just because a trip falls within a prior authorization guideline doesn't mean it's a good utilization of trip. Certainly from the managed care's perspective and cost, but even from the member, you know, if a member, and Medicaid members are frequently very transient and change addresses all the time, if the member has went to a location that's now 30 or 40 miles away from the location they used to be on their address for, you know, spending an hour a day in a vehicle to go back and forth to an appointment is not good use of members' time either. And when you can identify those things and you have a consistent communication chain with your case management partners at your managed care organization, with the people in behavioral health, if it's a behavioral health issue that's kind of driving some of those things, and a regular communication chain to report those things, and you're not just an outlier providing a commodity, then when you identify those circumstances, you have someone you can talk with and work jointly with about finding a better way to fix things. Doesn't mean you can always change it, doesn't mean there are always reasons behind it, but you should be evaluating it as a partner to find a better way to deliver service.
It's so interesting because I think we talked about this a number of years ago when you were having a bit of challenge around addresses. And so, you know, it's really becoming much clearer to me today when you say, you know, if because you're the transportation provider and you know the latest address, if that information isn't getting its way back to the plan and the plan isn't, you know, how do you help everybody correct data and make sure that it's current, you know, the most current, because they may just send you back to the old address if you don't partner together.
Right. And we have the ability to provide limited view access into our system so that they can look at member records. So engagement people from the plan can come back in and see things like, hey, members got a note that he didn't list to us or he didn't call back with Medicaid. Because Medicaid doesn't typically formally update a record until the member themselves call Medicaid directly to do so, which members don't do very often. But in transportation scenario, they want picked up, they need picked up, they need you to have that data and information. And we're typically saying at the reservation process, give me a phone number and an address information that I can contact you back in the next 48 hours. So generally everything that we have is.
Yeah, I'll just jump in as I think we continue to have a bit of bandwidth challenge, but absolutely. What about care coordination, Chad? Do you have any thoughts or insights around, you know, transportation can partner in many different ways?
Right. Yeah, I think, you know, as well as kind of mentioning and kind of touching there and getting into that space where, you know, where can you contact members? Who do we need to contact? What are the services they're seeking? Obviously, you know, in many instances and for types of, you know, appointments that don't need prior authorization, you know, the NEMT broker knows about that trip that's going to happen, not what the service is going to be, but knows that there's going to be appointments before we know it and the latency of those claims. So I think, you know, an effort to, you know, who's going on trips, where are they going, matching that up with, you know, who are members internally within the plan who are on hotspotter lists, who, you know, is on a HEDIS report, they need to get, you know, vaccinations. They haven't had their vaccinations. Well, they got, you know, appointments coming up. We haven't been able to get a hold of them. Can we get lists proactively when trips are scheduled, you know, have our hotspotter list when people come in, boom, I got them. Now we need case managers to contact them. I've got their information. I can get them. They're going to be in. Make sure they get their vaccinations, you know, for kids. Make sure it's this, that, or the other. You know, there's lots of things where you can intervene there. You've got them on the hook, you know, and typically in the Medicaid space, for me, it was, you know, lots of vendors and intervention, you know, type of things were pitched. And if you could get a hold of 30% of the people, like that's kind of the watermark. If you told me you were getting hold of more than 30% of the people, I kind of wouldn't believe what you were saying, because, you know, the reach rate is really hard with this population. And so here you've got, you know, if you're actively fishing, you've got those lines in the water. Here are my members that I'm looking for. And then when they hit, well, you got to, you know, you got to have a process in place to go get them, you know, get them into case management, get them talking to your folks, get them to the appointments they need while they're there. I mean, I think that's a huge advantage, and, you know, something that could be missed, an opportunity that could be missed pretty easily just because of all the things that are going on. And if you're in that kind of set it and forget it mode where you hired a broker and they're just doing their thing, you know, that's something where, you know, there's some extra value there that's probably, you know, could be untapped if you're not able
it's untapped, and it's hugely impactful. I mean, you know, especially when we're moving towards value-based, you know, metrics. And how do we make sure, well, they're coming in for an appointment, how do we, you know, identify the 2 or 3 other possible services and combine that really to jumpstart and accelerate, you know, their care journey. And I think that's just really insightful, and really one of those big value nuggets that come out of partnership that I frankly, I personally didn't see. Before we've had this conversation, and I marvel at the, you know, this is why you have a deep partnership, and the value goes just beyond, you know, transportation dollars. It really is about elevating the care that the organizations are delivering together. So, you know, absolutely exciting stuff. I wanted to, so I appreciate the fraud, waste, and abuse conversation. Let me get to the next topic. Oop. Yep, that's a big 3. So, you know, when we look at cost controls, we all know that, you know, transportation and all its ancillary functions and steps in the process can be expensive. What are some of the areas of concern or focus, Chad, that you have when it comes to cost controls?
Sure. Yeah. And I think, you know, touched on a few of them a little bit earlier, but I think, you know, one of the double-edged sword here too, and looking at it, you know, from previously being in, you know, a plan CFO seat, was more transportation means more cost, right? And then I don't want everybody going everywhere, and then it's, you know, costing a ton of money. But the other side of it is we're getting people, you know, getting people where they need to be appropriately, you know, helps their care, is better value for them, better value for us, you know, everybody involved. And it's the most, you know, the clearest path. You're worried about fraud and abuse, which we just talked about. But I think, you know, one of the biggest things is, you know, realizing through, you know, working with it that, you know, as we kind of mentioned earlier, the network and those prices per ride or per mile and the different arrangements with the providers, the individual providers with your broker, like that's all on the broker, right? You got to rely on them. They need to control that. We need to hold their feet to the fire on, what are you paying this driver? Like, why are we, you know, is there more cost here? We need more drivers there. And I think that's appropriate, and something, you know, Will would admit they work on, you know, a lot, making sure that's appropriate, coming up with good solutions for those situations. But when you're talking about, you know, just the utilization, well, you know, gosh, these people are taking so many trips, and, you know, in my mind, well, that's the plan's responsibility, right? There are members, they're seeking medical services in non-fraud cases, but they're seeking these medical services. We need to have a handle on what services are they seeking. Why are they seeking them? Can we help them with that condition, or can we help them go to a more appropriate setting? You know, you got some members, they're used to a certain place, they may move. You know, we talked about members being transient. Now they're going so much further than they need to. Do they know that they could spend less time in a car? We've got a, you know, higher quality provider that's, you know, got great ratings, could be better for you. You know, can we do that for members? Can we let them know, hey, you could do gas reimbursement for you? You know, we could do those sort of things, or we could get you on, we get you a public transit pass, and you could use this, you know, for every day of the month to go get groceries, go to your appointments, you're close to the bus line. And, you know, Will's group, they work on those things, trying to identify members there. But just the general utilization, I think that's the difference really is, you know, utilizations in my mind is on the plan. We've got to manage that and be more proactive where those members are going, how often they're going, and then just the pricing structure then is all on the side of your broker.
Right. No, it's interesting because, you know, you talk about utilization being driven by the plan. I will, you know, from a Momentm perspective, you know, our platform offers brokers the opportunity to manage bus passes or mileage reimbursement and or multiple contract types, as well as TNC. So we're enabling any and all types of solutions, and then we turn it over to the brokerage and say what's appropriate, and you know, and watch them do their thing. So you know, William, we were just talking about some areas of cost control, and you know, what are some of the areas that you look at and manage actively?
Yeah, and I apologize. I'm in the middle of a thunderstorm right now, so it's wreaking havoc with my internet connection. But I think one of the things that you want to make sure of is that your broker that you're working with doesn't necessarily have a one-size-fits-all model for service delivery. If you just have a contracted rate and you hand it out to all the providers and it's a take it or leave it, you can certainly create scenarios where you have wide areas of service that are just not being covered because there isn't anybody who can work at that contract rate in there. Simultaneously, some contract models don't work in really rural areas or in areas with odd coverage circumstances where there's a lot of out of county trips and things along those lines. So you have to constantly be reevaluating your network and your utilization process at a micro geography level. So we're looking at county by county, what is going in, and there's 92 counties in Indiana for a state this small. County by county, what's going into each county, what's going out of each county, who are providing those trips, where are those trips going to? Because if you see a shift in more trips going to the west than going to the east, then go and negotiate with your providers to the west of that area and see if they'll come over for a less expensive rate to be able to come back and transport people in conjunction with it. Indiana's geography is a little bit unique in that regard because we have 92 counties. Over 40 of those counties don't have a city that has 10,000 people. 6 of those counties don't have 10,000 people in the entire county. So you have to get a little bit creative about who you get to support and the cost methodologies that you use to support a lot. So, I mean, we have structured rates that are standard mileage rates. We have extended distance options. We have subscriber pickup for things that are like high risk trips like dialysis and chemo radiation that we don't ever want disrupted. That will custom rate to ensure that all those trips and all those standing subscriptions ordered appropriately. We have circumstances in certain localities where we have day rate models in place that we can buy the vehicle for the entire day and make it take whatever trips we want it to be able to take at whatever schedule we want to be able to take that trip out, because that way we can control and go, hey, there may be 3 really cost-effective trips wrapped in here, but there's 3 really non-cost-effective trips wrapped in here. Through a day rate, I can get all 6 of them picked up with one car in that area and probably couldn't find another car that would go in and go get half of those trips. So you got to be flexible in your model, and you have to always assume that there is something to be evaluated that you might be missing. I think I drive the network provider team crazy all the time because I come back and go, oh, looks like we've got to turn up in this county. We got to reevaluate what caused that and what we're going to do differently. Well, those are going to happen from time to time, but you always have to take the time out and stop and go, is it something that we're doing, or was it just a blip on the radar? Because if it's a pattern that we created, we need to adjust that pattern and come up with a better methodology to be able to deal with it. It's not just the managed care team downstream just to pay the bill because, we didn't maximize our efficiency. We have great technology tools in place that allow us to be able to see where the low-cost providers and what the alternatives are. We have great relationships and communication lines that we have with the managed care. Certain members are driving up costs based on member behavior, things that they're doing. How can we get involved together as a team and try to create that? But you just can't stand on your laurels and say, I sent out 4,000 trips today, 4,000 trips came back. I don't have anything else to do. There's always room to be able to evaluate, improve on both the cost control, the utilization, and the level of service quality.
I appreciate that. I think we'll jump to our last topic and talking about a responsibility approach and being sensitive to local needs. We all appreciate that the closer you get to your local communities, the more you can deliver better healthcare. And so in what way do local differences come into play from a transportation perspective?
Yeah, Will, I'll let you take
Well, I
this
think one
first.
area that I always like to point out within the locality is from our perspective, local geography is the driving force in any transportation plan. I think there's two tendencies from contracting standpoint to look at when you're looking to contract a transportation broker. One of them is, who did everybody else hire? And I'll just do what everybody else did. Or the second option is this is a commodity I'm purchasing. What's the cheapest price that I can get for the commodity? But the reality is, if you're not evaluating what your local plan members look like and what the geography of your local area that those plan is being covered under, it may end up not being as cheap as you think it be. And while transportation is not like cardiac care, we're not doing heart surgery to save a member's life. If that member doesn't successfully get to that cardiac care, then they're absolutely detriment to his health, and we're making the situation worse and causing more member abrasion. So if you have a lot of rural areas, what is your transportation partner's plan to be able to provide for those rural areas? If you're in a major metro that's heavily utilizing mass transportation, how do they deal with and build mass transportation into their local partnership program to reduce overall costs? Because typically mass transportation costs are a quarter to a fifth of what the costs are for a lot of other types of commercial transportation. If there is a vehicle shortfall, are they finding creative and innovative ways to deploy and utilize TNC programs in conjunction with their model? How are they restructuring what they do in their network outreach, and what types of negotiations are they having with the providers about the trips that they carry that can help assure, A, that your members are where they're supposed to be in a reliable, on-time way, two, that they're constantly looking at the cost of that service and seeing how it can be reduced, and then three, making sure that the service levels are all appropriate for what they should be. Are you getting the right cars to the right trips? Are they being delivered in the right way? And if you simply just take a mass market model and go, it works in New York, it must work in Indiana, it's highly unlikely that will be successful, because New York has an entirely different underlying transportation infrastructure. Its members are rolled out geographically in an entirely different way. Can even be as simple as some of the issues that you are dealing with among your member population. Indiana, unfortunately, has a very high opioid abuse, methadone utilization community within its Medicaid population. Those trips are trips that typically only take 5 or 10 minutes for the clinical appointment. Do you have a model that allows you to get back in, get them picked up within 5 or 10 minutes and get them back home, so it's a quick turnaround trip? If your trip is based on scheduling guys walled out where they go back and pick up in hours, and it's not the same provider picking them up every time, you may not be able to do that. So that micro geography of your climate and what's happening locally in your provider community, in your geography community, in your member community, makes a huge difference on cost and satisfactory service in any transportation brokerage model.
Yeah, I think
Really
I,
appreciate, go
I'm
ahead.
sorry, I was just going to add on to that just a little bit. And some of those in geographies, I think, it aligns a little bit with the medical plan network strategy as well. I mean, you're looking at, dentists within certain, so many miles of all your members. Now you're potentially creating issues for an EMT or longer trips in instances too. So I think there's some crossover there, from my perspective on the, with experience on the plan side on, are we willing to contract differently because it alleviates pressure on the NEMT network and the length of rides, the number of rides, if we can get people to where they need to be. So it's a slight nuance, but something that can be, like I said, is often overlooked if you're not really in the details and collaborating enough to know what's going on, and you're just kind of paying the bill on a monthly basis.
Mhm. Appreciate that. Look, we're coming up to close to 10:02, and so I just want to ask one wrap-up question, and I'll start with you, Chad. You're from the plan world. So what is one learning or one ask you would want to share about brokers? What do we need to know?
I think it's a hard business, really, and just the number of providers you need to contact. And, you see that more, being involved with that benefit a little bit more. But I mean, honestly, it's hard, it's hard at times to pick up your kids on time from athletic practice or school. And then you're talking about all these members, high needs members. It's daily, it's here, it's there, it's hundreds of miles, 100 miles in some instances. You've got people in rural areas that need dialysis on a regular basis. I mean, it's pretty hard. And to make that work, I think you need to collaborate often, and know what's going on, have your pulse on them. These things are going to happen. You're going to have issues that you're going to have to manage with this population. And if you don't find out about it until you get the price tag after a month, or you see what's building, the shock of that, can be, resounding, and it's not going to create a good relationship. You're just going to be looking for a new broker if you're not really actively working with them and know about the challenges and working together to try to overcome them. If you are doing that on a regular basis and know what's coming, not to say that it eliminates the problems totally, but there's going to be problems. It's much easier to swallow, from my perspective, from being in a plan when you know those ahead of time. You're working on them together instead of just being like, hey, here you go. Sorry about this, but you got a huge bill, and it's because we had an overload of the network and everybody was going to SUD trips. And that's not something anybody wants to be in, including the broker. So I mean, I think just collaboration early and often, and just partnering really in what's going on with that benefit, is in my mind key to, doing business with a broker and selecting a broker.
Appreciate that. That's really great insight. And let's ask kind of the reverse question of William. So from a broker perspective, what do you hope that plans really appreciate in terms of what you're trying to accomplish?
Well, I think at the end of the day, I always brush off the concept of being called a transportation vendor. I don't like to be called a transportation organization. I like to be referred to as a transportation partner, because at the end of the day, transportation is a fundamental aspect in the social determinants of health structure. You may have all the best clinical resources in the world available to you, but if your members can't get to them and get to them reliably, they will not provide a great clinical benefit to your plan. They will not try to cost control to your plan. And if I am simply operating as someone who goes, here's my bill for the number of trips that we went out, that's the limit of my responsibility, then I'm not bought in and I'm not invested in the outcome of your members and what's happening with them on a day-to-day basis as a partner to your program, to help find unique and identify ways that we can work with you to be able to make your plan better, to be able to make those members access better. Everyone wants greater equity. Everyone wants greater control of the social environment that's impacting America's healthcare programs. And as a partner, we cannot simply be just, hey, I ran 1,000 miles today, or I ran 100,000 miles today, or we ran 1,000,000 miles today. We have to be constantly in communication with our partners. What can we do to make our program better and operate specifically for the members that you try to serve? And if we're not doing that adequately, what adjustments can we make today, next week, next month, next quarter, next year, to try to be able to do those things functionally better? Because transportation, while it may be commoditized in terms of pricing, it is not commoditized at all in terms of delivery. And we have to understand that, and we have to work with it as a quality add to a program and find ways to make it better and work so that it doesn't cause member abrasion and it does not cause any negative impact on health. Our motto around here, and we say it all the time, and it's printed on the walls, is our goal is to end transportation as a barrier to health. If you don't have a good transportation partner, then inherently the thing can become barriers to health. And it takes creativity and it takes bend over backwards. And even in the best of cases, if you have the best provider partner in the world, it still doesn't mean the program's perfect. Cars break down, people don't show up, weather happens. Got a thunderstorm, knocked out my internet in the middle of this. Things happen along the way, and you got to be able to deal with those curveballs. And it's as important that you have a partner who steps up and takes responsibility. And when something went wrong today, here's our residual plan to make sure it doesn't go wrong again tomorrow, is
Right.
as important as price, its contract negotiated, how many cars it has in its network, because things aren't, no matter what their preliminary plan is, no matter how many other states or communities they've done this in, something is going to happen tomorrow that wasn't anticipated. And you're going to have to field that ball. You're going to have to make that play cleanly. And then you're going to have to learn something from it to make sure that it doesn't happen again. And that requires cooperation and partnership on both sides.
Incredibly well said, William. And I just want to say that I thank you for your partnership and allowing us to help you and Chad deliver value to the good members in the state of Indiana. I really take away from both of you the constant desire to improve. It's always about refining and focus and return and challenging assumptions. We get lots of data. There's lots of things that we can do creatively to improve the healthcare journey. On behalf of William and Chad, I'm Mitchell, and turn it over to Patrick and say to all the members of MHPA, thank you so much for joining us this afternoon. It was a very interesting conversation.
Awesome. Well, I want to thank you guys, William, Chad, Mitchell. This is a great presentation. In many ways, this can be the first step of getting Medicaid patients their care. And so for that very reason, it's so important. So again, thank you for your expertise and this great information. Contact MHPA if you have some follow-up questions for our presenters, or directly reach out to Momentm. I'm sure they'd be happy to chat with you, but you can also go through MHPA if you want to chat and follow up with these great presenters. Additionally, you can revisit this webinar. We're going to put it up on MHPA's YouTube page. So take a look there. You'll find it if you want to share it with your colleagues. And then lastly, don't forget MHPA 24 is in Indianapolis this year, mid-September 11th through 13th. Our call for presentations is currently open if you wish to submit a presentation for consideration. But with that, I want to thank everyone for their time, again, our presenters, and have a great afternoon. Thank you all.
Thank you.
Thank you very much. It's been a pleasure.